the last 1.5 days, we've seen that the cornea has been the hero and voice of refractive surgery, but now we are digging deeper and diving into phakic IOLs, and I'm going to speak about IPCL version 2 and beyond. So definitely there is an unmet need because not every patient can be treated with corneal laser. I think we would all agree that very high refractive errors, cases where the topography is suspicious or your corneal pachymetry is inadequate, where your extreme post-operative K values are expected, or even in regular high refractive errors where a corneal laser procedure is going to induce a high spherical aberration, there's a higher risk that the patient is going to end up with poor night vision quality. In all these cases, I would urge you to not consider IPCL or phakic IOLs as a last resort, but much earlier in your decision-making process. I feel like IPCLs are not, they're not a niche surgery anymore. You cannot escape it. And it's a very integral part of comprehensive refractive care that you offer to your patients. So an IPCL is a posterior chamber hydrophilic acrylic phakic IOL that's correcting myopia, hyperopia, astigmatism, as well as presbyopia. What it's doing more is that it's preserving your corneal biomechanics, it's preserving corneal optics, and the version 2 has been available since 2017. What's new is that it has a central hole, not just a central hole, it's conical in shape with the intention of reducing scattering of light in photopic as well as scotopic conditions. It has a 6 point of contact in the sulcus, so it has these haptics with a spring effect so that it's designed for better vault predictability. It also has these 2 edge holes at the optical margin that are to be oriented towards the eyebrow, and it has multiple holes in the optic design to allow better flow of aqueous. I think what is best in the IPCL version 2 over all other phakic IOLs is the wide range of powers that it's available in and the ability to customize whatever error size, optic size that you wish. So it's available in regular range to correct up to 22 diopters of myopia, but customizable up to -30. I think I've used up to -28 power. Even in hyperopia up to +15 and a toric correction up to +10. It's also available in a wider range. All other models are available in 4 sizes, but this is available from 11 millimeters size up to 14 millimeters. This is just a quick case to show you that every myope, you expect it to be a large eye, but sometimes, though the axial length is long, there is a relatively smaller anterior segment where there are very steep K values, a shallow anterior chamber, a small white to white. So this was a patient with a 10.6, 10.7 millimeter white to white, and the ICL was suggesting a 12.1 since then size ICL, since that's the lowest that's available. But in every such case, I would consider a smaller size phakic IOL. I went ahead with an 11.7 IPCL and ended up with a perfect vault of like 600 microns. So the advantage of a toric IPCL is it's a smart design wherein you don't have to rotate any of the toric versions of their lenses. They're all designed for 0-180 placement, so that makes your life much easier. It's just a single marking that you have to do. And the other customizable part is that it's available for larger optic zone sizes up to 7.25 millimeters if you have a patient with a larger pupil size. But then you have to be careful about the vaulting, that you go in for a slightly downsized lens if you're going in for a higher customized optic size. So this is the surgical technique, which is pretty routine, but I'm quickly going to go through simple steps. Yeah, I found it. So this is a toric lens, so a 0-180 marking, and a clear corneal temporal 2.8 millimeter wound is sufficient for the IPCL. HPMC is my preferred choice of viscoelastic. The loading is not complicated. Simple loading, tuck the edges of the lens in, and then you can either load it taco or reverse taco, whatever's comfortable to you, and inject it into the anterior segment, ensuring that the orientation, both the edge of the optic margin holes are directed superiorly, and there is also a knuckle at the leading left edge and the trailing right edge. and tuck the haptics below and ensure a thorough removal of the viscoelastic. The version 2 of the IPCL is also a more pliable material, so that makes it easier to explant it without enlarging your wound. So this is a case of cataract, wherein I'm using the one of the many holes at the haptic to grasp the haptic, and then hand over hand technique, which means that keep a sustained pull with one hand and use another forceps, and keep pulling with two forceps further and further, and the lens will fold upon itself and it can be removed, so that with the same 2.8 millimeter wound, you can then proceed with phacoemulsification. So these are my outcomes. It has excellent predictability. It's absolutely safe. The stability of outcomes, as well as the target, like almost 100% patients lied within one diopter of intended spherical as well as cylindrical correction. So I would conclude by saying that it's bringing really high and complex refractive errors into a treatable range. It is a cornea sparing and reversible procedure, and it's a very powerful tool to have in your armamentarium that you offer to your patients. Thank you very much.